Hello, everybody. Welcome to a new podcast of Kinetodidactica. My name is Bogdan. I'm a passionate physio from Romania. With me today is my colleague and our colleague from Belgium, Romain Giop, who is a physiotherapist with great interest in treating headaches and migraines. Hello, Romain. Thank you for accepting our invitation.
With pleasure.
Romain, let's start with this. Can a physio treat headaches? Because, we treat like back pain or neurological conditions or, scoliosis, but headaches?
Yeah.
It's not so very often that the physio see headache patients.
Exactly. So there is two steps in the way of answering to a question. The first step would be, okay, but what is headache exactly? And one of the common things that we can find in the population and the knowledge of science is a lot of people don't know exactly what's headache and what is the mechanical and the physiopathology behind the headache. This is the first step, and a lot of...
So I would say headache is not a pathology. Headaches.
It's a symptoms.
It's maybe like an umbrella of symptoms.
Exactly. And this is the first step when I... provide courses. It's understanding the whole umbrella of headache and what's the mechanism behind and beyond this headache and then I explain one thing which is really important to us as physios is understanding that the headache is mainly concerned about trigeminal nerves. And there is a neurological link between the upper cervical spine and the trigeminal nerves. And so we get a convergence. And this is the first mechanism that could explain how and or when physios could help for treating or decreasing headache.
So you say that some headaches originate in the upper cervical
Yeah, or could be aggravated by bad inputs from the upper cervical spine.
Sometimes we were using this, I don't know, tell us more about this thing. We were using the term of Arnold nevralgia.
Yeah.
Which describe pain from upper cervical coming to the front, from posterior to anterior, on the head and maybe behind the eyes. But we know that we don't use this nowadays so much. Huh?
Yeah, exactly. From a scientific point of view, from a concept point of view, if I could say and use a parallel of the rest of the body of the physio, it's like a big myth, like the same myth that we've had previously about lumbar flexing or pelvic tilt, or transversus abdominis for low back pain. There is first, many times ago, in the 80s, a lot of doctors publish about that headache and that kind of headache. So, but they publish quite a bit bullshit or not good reference things. And at this step, we didn't had so many knowledge about the physiopathology and neuroscience, and now we got. And now we understand that the real Arnoldite nevralgia is a pain or a loss of sensation just over there. But when the pain goes
local,
when the pain goes in the head, this is quite more like a trigeminal convergence with the upper cervical spine.
Okay.
For example.
Okay. Another term that we hear a lot, and it's migraine. Yeah. But not. Sometimes it gets a mixed or confusion between migraine and headache. Yeah. Not all headaches are migraines.
Exactly. And not migraine, and not all migraine
produce headache.
Exactly.
Okay.
So this is a big myth and a big confusion in the general population, and this is quite funny when you read the paper. This is a big confusion that still remain for general practitioner doctors, for MD, for example. This is quite a bit confusing, and so we get migraine, which is a typical disease, a neurophysiological from the central nervous system disease, which have a real feature and pattern of symptoms. could have a headache or not, but when I'm teaching, I'm trying to explain more like headache is like when you say car, and migraine or cervicogenic headache or Arnold would be like a type of car, like you would say some brands, some BMW or Dacia or something like that would be quite typical, and every car has its own typical things like okay, she's good at it or bad at it, or she's really powerful or less powerful. This is bigger car or smaller car, and this type is really like a good parallel to understand headache. And so as physio, of course, we could help some headaches, but we have to identify what kind of headaches the patient have.
So not all headaches,
of course,
are treatable.
Yeah.
I'll make just a short parenthesis because you mentioned several times now. If you want to hear, if you are a physio and you want to learn about treating headaches and which and how, Romain is part of the Romanian OMT program, OMTRO. So he has a 3-day seminar. So there he explains a lot of this information there, and assessment and clinical rationale, and then ways of treating and interventions. So we can find him there, and also he will try to run a project in Belgium about manual therapy also. So if you are interested, you can find more there. Coming back to this thing, so migraines is one thing. But then we have also like we talked about cervicogenic headaches, which originate in the cervical spine. And cervical spine, and we have maybe tension type headaches, which originate maybe in the muscles of the jaw, of the temporal muscle.
Of temporal muscles. And what we notice when you go in the tension type headache, the more the patient is chronic, the more you can find some inputs in the cervical spine again. So it's like an upper over sensitization of all the structures.
So the threshold of the structures, not only around the jaw or the head, also cervical become
and upper trapezius
lowers the threshold. So the impulses will create more rapidly a stimulus that will create pain.
Exactly. Exactly. It's a good summarize of it. And so all the assessment is based on quite useful clinical examination, which is really easy to do. And this is the step. For example, you mentioned OMTRO. When I'm teaching OMTRO, I am in the first part explaining all the structures, all the mechanism behind. Then we go to explain really good all the type of headache and how could we differentiate from the speaking assessment, I would say, the anamnesis.
The history take.
History, yes, exactly. And then that could give you a first idea of what kind of headache the patient is remaining. And then we go to the clinical examination, which is really could included or excluded your patient, like, okay, he need me or he don't need me.
When is a headache a red flag? So
again, we have to. So an headache alone is not that much a red flag. Again,
if it's only the pain,
it's not a red flag. It doesn't mean anything like this. That's why we need more information. And this is really common. Like when you isolated the red flags, it's quite the same for all the parts of the body. Just a red flag alone, it's not enough to be very aware of something or something like that. Would be certainly a headache associated with strange symptom or really uncommon symptoms. So a lot of people are a bit afraid of that and that's why it's not so easy to find some specialist in the headache field because like it's not a well-known structures and physiopathology. A lot of physios, I noticed that are afraid of touching the patient or do really some soft technique like a massage of the skull or something like that, because they have the fear that you mentioned, I think, of that is dangerous. That is
okay.
a red flag or something, or I'm afraid of it. This is the case.
Okay, we understood the red flags, but what can really a physio for a headache do as techniques, or from where you go with the assessment? What would you expect to find in the assessment that will say, okay, I can help with these techniques or these techniques? Because we know we sometimes we try to work a symptom modifying therapy and
exactly,
an improvement in the range of motion, but what do you expect to find here?
Yeah, it's quite both. So it depends on what we will find on the assessment. But as usual, and as all the concept like in Omtro or something like that, the physios and the good evidence-based practice physios will remain in providing 3 types of treatment: education, manual therapy.
Education towards the patient. That's
exactly
okay. To be more clear,
explaining the mechanism of pain, explaining the inflammatory response or something like that, and the reassurance of the patient, which is really, really important. And exercises providing, of course. And the goal of it would be mixing the 3 of them. And depending on the type of headache, depending on the design of your treatment plan.
Yeah. So you would, I think, do like a graduate exposure to loading to the stimulus. So maybe you'll start with manual techniques.
It depends on the type of headache we will identify. So, example, with migraine people, we'll make more exercise and more education.
Although the migraine patient I work with, they really fear working out because they fear that working out or moving will induce the migraine.
Exactly. That's why the pillar of education is really important for migraine people.
Yeah.
And with cervicogenic headache people, which is like subaigu or aigu phases, it's really like you don't need that much exercise, a lot of manual therapy, and that would be really easy to fix.
Yeah, just to translate for our non-French speaking persons, the native language is Romanian is French, so aigu and subaigu, it's acute and subacute, but it's okay.
Sorry.
No worries. Come on, it's not your native language. So.
We're trying to.
You're doing a very good job in English. So
I'll do my best, by the way. And the other thing is with some touch type headache, this is more like exercises providing. So that's could have a good idea of the way of we design the things. And of course it will be like the same way of thinking a patient. Like you will probably find some symptoms and some loss of range of motion. And you will combine the approach of trying to apply some technique to recover the range of motion or to modify the symptoms. And
you'll try to find movement that produce the symptom.
Exactly. By palpating or by contracting the system, like in the Mackenzie concept or Maitland.
So you'll try to see if it has movement that provokes symptoms, and definitely movement. If you have this type of mechanical pain, you'll have movement that alleviate the symptom.
Exactly.
And maybe you try also to find some tension in the muscles or sensibility in the muscles.
And you'll careful about the trap. So we are not looking like tension from but this is really good to mention it. It's not like a center-based approach. Therapist. It's like a patient-centered based approach. So about the tension, I know there's a lot of debate and about trigger points. It's more like not feeling a trigger point. It's like more reproducing something to the patient. And this is really...
It's like you don't search, because there's a lot of debate around trigger points. If they exist, if they don't exist, what it is. But so you don't try to really like using that chart of trigger points or to find where is that trigger point. You just try to find sensitive muscles. And to raise up or to graduate, raise their tolerance to stimulus. To pressure. Or to movement. Or to loading.
And the thing I learned from my last years of searching in science is when I really find some hypersensitive palpate muscles, I really try to first making some manual things, but the second step and the more early possible would be put a loading on it, like you mentioned, so it would reinforce it. So imagine if we find a really upper trapezius really sensitive, like painful and reproducing some headache. I know in my head that in the weeks to come I will put some load on it and train the muscle and do less manual things. That's the thing that changed to me in my practice, I would say, in the last 2 or 3 years.
Do you try through your assessment to see if it's like a movement-orientated patient, let's say, or a patient that really needs touching? You know, there are the types of patient, they say, I love, massage or do me some techniques. I came to you to, or there are those I like to move. And do you see this? Do you try to observe this in your assessment? And if yes, do you guide your techniques through this thing?
Yeah, it's the goal of the patient-centered approach. It's like, okay, what he is, what he likes, and what he expects from us, and finding a compromise and a good middle way of making the things. The only thing I know is I'm trying to not have a patient dependent on me, So that's why I'm trying to just create a confidence between each other, and then slowly making it that okay, but if you wanna leave me, and you will have to leave me one day, do some exercise or do return to the sports activity or something like that. But this is not. I would say I will always do that, but my timeline would change depending on the patient. I don't know how you do the thing, but
can you get rid of a headache?
Can you
get rid of it? Like never have it. Go to therapy, and it goes away, and you'll never have it anymore.
Depends on the type of headache.
Because this is really important, like the outcomes that we have to the patient. What we say to a patient, okay, you come to me for therapy, because all the patients, some ask, some don't ask, but they all want to know. And also us, if we have a pain, we would like to know if it will go with me the rest of my life, or I will do something, some intervention, some therapeutic intervention, and get rid of it.
So it would be depending on the type of headache, and we will be able to clarify it. But many times, and the most frequent headache are genetic, coming from a genetic issue.
Like a migraine.
Exactly.
Migraine. Okay.
So telling to the patient, I will cure you.
You cannot cure a migraine.
Exactly. So you can decrease the
frequency, maybe?
The frequency, the invalidity, the disability.
Yeah.
But you cannot treat it like, okay, it will disappear. And
but a cervicogenic headache or a tension
could
type
be
headache?
A cervicogenic, because this is more a musculoskeletal issue. So and only that. So it would be quite easier to really stopping the headache for years and years.
Yeah.
But it still remains that the pain is a complete part of the body, like the emotion, that like being happy, being sad, or something like that.
Yeah.
So it still remains impossible to make a promise to the patient. Okay, you will never ever experiment a headache again in your life.
Yeah. So we should keep this in our mind as a message, because sometimes we promise to patients things that we cannot really keep our promise to them.
Exactly.
And afterwards the disappointment may be bigger for that patient, and that can be really a road to chronicity.
Exactly.
So I think this is a very valuable message what you gave us.
Yeah.
And it all starts with a very good assessment.
Yeah. Exactly.
Yeah. So we can be part of a team that treats headaches.
Of course.
This is the message.
And this is highly recommended in the scientific paper.
Yeah. We thank you so much, Romain.
Thank you.
Job.
Thank you to all.
And we are eager to hearing you in the courses and in congresses, because you participate in the National Romanian Congress.
Yes.
You participate in
Notre Congress.
Yeah, you are very open for the Romanian community of physiotherapists, and we thank you for that.
Oh, thank to you.
I don't represent the Romanian community of physiotherapists, but I thank you in my name and in some colleagues of mine.
But thank you to invite me as guest, and it's always a pleasure to share some things.
So we are waiting for your feedbacks, your replies, some questions if you have.
Yeah.
Put them on the comment.
Yeah, we'll respond.
And in our time we'll respond. And if you appreciate the Kinetodidactica podcast, give us a hint. We are we feed on good feedback.
Yeah, exactly.
But your honesty, this is what Alexandru Sideri says. This is his quote. Your honesty makes us better.
Yeah.
So
thank
you.
Thank you, and I hope to see you
very soon.
Yes.